Thank you, everyone. Thank you, everyone, for joining us for another wonderful interactive session. As I mentioned, we have a series of session coming up specifically on pain. So last week we have heard about an intro, including the assessment of pain. Today we will be moving on to the first step of WHO ladder and adjuvants also. Today we have as our faculty Dr. Mary Abraham. Dr. Mary Abraham is an anesthetist trained from AIMS and she is working in neuroanesthesia. A few years back, she happened to come to us to Pallium, India, where she was with us for a few weeks and she was already doing chronic pain management. And now she's working in Delhi at various hospitals as a pain specialist. I think I'll stress upon this pain specialist part. And she has written a wonderful book on conquering pain. And she's our faculty for, I think, from the beginning of our echo session. And she does wonderful sessions for the doctors. Welcome, ma'am, once again for another session. Thank you so much for coming again.
Thank you, Sri Devi. As usual, you have been so generous in your compliments. I'm not sure if I deserve it or not, but anyway, once again, it is a pleasure and honor for me to take this talk. And I'm very happy to be part of the Pallium faculty in taking talks on pain management. So can I just share the screen, please? Okay. Without much ado, let me move on to my presentation. The broad outline of am I audible to everyone?
Yes, ma'am. Yes, very clear.
Okay. The broad outline of my talk would be, I'll talk about the basics of the WHO ladder, analgesic ladder, focusing on the step 1 and step 2 drugs. The step 3 will be done at the subsequent session. I will also be talking about the adjuvant drugs and with specific emphasis on drugs for neuropathic pain. Now, the WHO analgesic ladder was devised way back more than 30 years ago. It was a step to manage cancer pain, and it was based on the recommendations of a group of international experts. And over the years, it has been translated into 22 languages, and it has served as a catalyst for treating pain, cancer pain worldwide. It has stood the test of time, and even today, we are following the WHO ladder. There may be a few modifications here and there, but by and large, we're following the WHO ladder. So what is this ladder? It is a simple, well-validated, and very effective tool in the management of pain. Be it cancer pain, be it acute pain, and even in chronic pain, you can apply that also. So it is a very stepwise approach. And before the ladder, that is before the 80s, people were dying in unnecessary pain for 2 reasons. The first of all was that there was a lot of drug regulation associated with the use of opioids. It was very difficult because of the very stringent laws regarding opioid use and consumption and dispensing. The law was very strict, and there was a hesitancy on the part of both the doctors to prescribe it, hospitals to store it, and also, a lot of people were worried about taking opioids also. But subsequently, that has changed over the years because it is such a useful drug. Then there was also stigma, which is still there, associated with the prescribing and taking of opioids. Even today, people say that I don't want to go on to opioids. I will become habituated to it. So, or the people may call me an addict. So there's a lot of stigma attached to the taking of opioid drugs. Okay. Basically, that was related to the misuse and abuse of opioids. But when the WHO itself devised this ladder, it actually legitimized the use of opioids because it is coming from the World Health Organization that you can take opioids. So that itself legitimized and removed a lot of the stigma attached to the use of opioids. Now, before I start my case, I'll just take a small case scenario and then we'll extrapolate this ladder to this case scenario. A 35-year-old father of 2 young kids had squamous cell carcinoma in the right upper lung. He had a deep-seated gnawing pain in the right shoulder, associated with burning and tingling sensation in the right arm. He was unable to sleep. The pain score was 4, NRS 4 in the daytime, but at night it went up to NRS 6. I'll come back to this case scenario at the end of the case. So before you apply the ladder and decide which drug to do, the basic thing you need to do before that is to do a comprehensive assessment of pain, because it is based on that you can apply the ladder. Okay, the treatment you start based on your assessment of pain. So a clinical examination is very, very important. So we are all familiar with this. I won't go into detail. The PQRSTU, I think it has been dealt with earlier. So that is very important. That by that we can assess the pain and the severity of pain, because this is based on the severity or the intensity of pain. And then you also need to know whether it is a nociceptive pain or a neuropathic pain or a mixed pain, which is a combination of nociceptive and neuropathic. We all think that cancer is nociceptive pain, but there is a lot of neuropathic element to it, in which case you need to modify the ladder, what you need. So this ladder is basically a 3-step ladder, starting with step 1, which is mild pain, where the NRS score may be less than 5. So it is in such patients, you can start off with a non-opioid analgesic with or without an adjuvant. And the commonly used drugs are paracetamol and NSAIDs. Now, if the pain is not getting relieved, or if the pain is moderate in nature and in intensity, with a score of say 5 to 7, then you may need to move up the ladder and add a weak opioid to the non-opioid. Okay, so you just add another drug, which is a weak opioid, and the drug that we commonly use is tramadol and tapentadol. Sometimes we may even skip the second step, and if the pain is very severe, we may directly go from step 1 to step 3. And step 3 is by substituting the weak opioid with a strong opioid, along with a non-opioid and an adjuvant. So using this ladder, you can treat satisfactorily up to 76% of patients with cancer. Now, what are the salient features of the ladder? The first important feature is that the drugs are given by mouth, that is per orally. And this is a standard route of administration of all the drugs of the WHO analgesic ladder, even for the strong opioids, which means that it is very suitable for home care or domiciliary care. It can be given by the caregiver, it can be taken by the patient, or it can be given by the nurse that is visiting the patient. That is a big advantage. Okay. And the second important feature is it is given by the ladder. I mentioned you start from step 1 and then you move up the ladder based on the severity of pain. Okay. The third important characteristic is it is given by the clock. That means it's a duration of action or the half-life of the drug that is determining the next dose. So particularly when it is a continuous pain, then you need to give the drug as soon as the duration of action of that drug is over. If you do not do that, it leads to a breakthrough pain and you get peaks and valleys. And that's not the way we treat pain. We need to have a constant level of analgesia, where the visual NRS score is less than 3 at least. So this varies depending upon the drug that you're using and its half-life. So if you're giving morphine, then you need to repeat it every 4 hours. So you have to tell the patient that you keep a time clock and you note down the time. If you're starting the first dose at 6 in the morning, next dose has to be given at 10, irrespective of the pain has come back or not. The next dose at 2. So like that, you have to tell the patient to give it according to the time and not according to the when the pain returns or not. Okay, that's a very important thing for getting a very good pain relief 24 hours of the day. Another feature of the ladder is it is individualized to the patient. which means the right dose is the one that relieves the pain. It can vary from patient to patient depending upon the severity of pain. For example, even if the patient is taking morphine, in one patient, he can get relief of pain with 30 milligrams of morphine. In another patient, you may have to give 300 mg of morphine. So it varies between patient to patient. And the right dose is not the total dose that you're giving, but the dose that relieves the pain. And also you need to tell them that in between, if pain comes back, how to treat it, that is called breakthrough pain. And all this has to be explained to the patient. Another important feature is you notice in the ladder that adjuvant drugs are added at every step of the ladder. And that depends upon whether there are other types of pain associated with the basic pain. So that I will talk about later. And of course, we have to pay attention to detail, which means you have to take the patient's age into concern, the body weight into concern. Is the patient asthenic, emaciated, or obese, or a muscular man? According to that, you can give according to the lean body weight, or the comorbidities. Is there renal dysfunction, liver dysfunction, the side effect profile? Everything has to be meticulously monitored. So the advantages of WHO ladder, why it has withstood the test of time, is that it is very simple, easily understandable by even the caregiver of the patient, validated tool. That means it has been found to be effective in managing pain. I said 76% of patients get good pain relief. And it is also very cost effective. See, like drugs like morphine and methadone and ecosprin and even the NSAIDs, they are relatively not that expensive. So a day's cost will not work out too much. It can be implemented across the world, even in underdeveloped countries, well suited for home care, and it can also be applied for acute pain and chronic non-cancer pain as well. Now, there have been modifications to the ladder. Like I said, sometimes you can omit step 2 and go directly to step 3. Sometimes you may have to add a 4th step to treat pain that is not responding even to the step 3 drugs. So in this modification, which was done in 2000, there is a step 4 in which you may have to add some interventions. Like in step 3, the patient's pain is not controlled, like about 10 to 15% of patients. Then you may have to give a nerve block, you may have to give an epidural or a patient-controlled analgesia pump or neurolytic block. You may have to use intrathecal opioids or spinal cord stimulation. So all that depends upon whether the pain is responding to the step 3, and only then, or even sometimes you can even implement it even earlier also. But usually if they're controlled with step 3, then you don't have to do that. Now let's come to the step 1 drugs. These include paracetamol, non-steroidal anti-inflammatory drugs, and they are combined, may or may not be combined with an adjuvant drug, and it is used to treat mild to moderate pain. Now, paracetamol is a term used in India, and abroad it is called acetaminophen. Now, it has predominantly a central action, that is, it inhibits the enzyme cyclooxygenase in the central nervous system. This is as compared to the NSAIDs, which inhibits the peripheral cyclooxygenase at the tissue level. So, paracetamol has got an antipyretic analgesic action, but it does not have any anti-inflammatory. Now, what's the dose? I think you're all familiar with it, but I just to reiterate, safe in a dose of 12 to 15 mg per kg every 6 hours. You can safely give up to 3 grams a day. It should not exceed 4 grams, and a single dose should not exceed 1 gram. Normally, the dose that we give is 650 mg Q6. It has a potential for hepatotoxicity, but it is not contraindicated in patients with liver dysfunction. You can give it in a reduced dose of 2 to 3 grams per day. It's safe in pediatric use up to 15 mg per kg every 6 hours. Toxicity only occurs in doses more than 90 milligram per kg per day. It can be given even as an infusion as 1 gram every 6 hours. Sometimes when the oral route is not feasible, like in patients with oral cancer or head and neck cancer, you may even resort to the rectal route of it. Now, the numbers needed to treat, or the NNT of paracetamol. Now, numbers needed to treat is a number of patients who receive a drug for one to have 50% of pain relief over the next 6 hours compared to a control. So the lower the NNT, the more efficacious is said to be the analgesic drug. With paracetamol 650 mg, the NNT is 5. That means for every 5 patients given paracetamol, 1 will get good pain. So the lower the NNT, the drug is supposed to be more analgesic, more potent. So if you look at the advantages of paracetamol, it's got a good safety profile. It has no adverse effect on the gastric mucosa, no adverse renal effects, no adverse effect on platelet function. It's tolerated by patients who have allergy or are hypersensitive to aspirin, and it does not affect the plasma uric acid levels. So it can be given in patients with gout. But there are drawbacks. First of all, it is the increased frequency of administration. Its duration of action is only for 6 hours, so it has to be repeated every 6 hours. It does not have anti-inflammatory action. It has a potential for hepatotoxicity, but that is when you're given in a high dose, or the patients with who are taking excessive alcohol, or if the body weight is less than 50 mg, then you give only up to 2 grams. So in cancer pain, it is very important. It's a mainstay of drug because of its safety profile and the opioid sparing effect. It can be added to each step of the ladder. It can be added at step 1, step 2, step 3. And by adding it, it can actually improve the NNT. Okay. Now let's move on to the non-steroidal anti-inflammatory drugs. Like I mentioned, this acts at the peripheral cyclooxygenase system. This is a very important enzyme in the arachidonic acid cascade, which ultimately produces the tissue and the tissue inflammatory prostaglandins. And it's the prostaglandins that are the important intermediaries in pain and inflammation. They are the ones that mediate the inflammation and pain. And they do it by a mechanism called peripheral sensitization, which is amplifying the pain. So it is very useful in nociceptive pain associated with inflammation. Now, if you look at the peripheral sensitization, like I said, when there is a tissue damage, there is a release of the tissue byproducts at the site of the tissue injury, which includes bradykinin, prostaglandin, serotonin, etc. And they form a kind of a sensitizing or inflammatory soup around the nociceptor. Nociceptors are the peripheral nerve endings for pain, right? Now, because of that, it causes an amplification of the pain signal. So there is a sort of all these and inflammatory mediators are all surrounding the peripheral nociceptor. So this is a diagrammatic representation of the same, where you have the nociceptor and the nerve endings, and this is all the inflammatory mediators that are released here. And this NSAIDs are actually acting at this level. They are preventing this action of the prostaglandins and the inflammatory mediators. So you can see where it's acting. It's acting at the tissue level by counteracting the effect of peripheral sensitization. Now, if you look once again, if there's a tissue injury, there's a release of phospholipids, which is converted to arachidonic acid, which is converted to prostaglandins in the help of this enzyme, which is a cyclooxygenase. Now, there are 2 types of cyclooxygenase that exist in the body. The one is COX-1, which is actually the constitutive or the housekeeping enzyme. And it is the one that mediates the physiological responses like protecting the stomach mucosa, the kidney, and facilitates platelet aggregation, which is so important for our maintaining our normal physiological function. But there's another COX, which is a COX-2, which is induced by the inflammation that is resulting because of these inflammatory mediators. It is this that is inhibited by the NSAIDs, okay, the COX-2. So NSAIDs is actually acting on both the non-selective NSAIDs, but by acting on this, it is having the anti-inflammatory. So there are 2 types of NSAIDs. One is the non-selective NSAIDs, which interferes with both COX-1 and COX-2. So it is even interfering with the normal physiological function of the body, along with the acting as an anti-inflammatory. But there's another group called selective COX-2, which is only interfering with COX-2. So it is preserving the COX-1 effects, which is necessary for our body. So if you look at the non-selective NSAIDs, the prototypes are ibuprofen, naproxen, aspirin. There are so many of them, piroxicam and ketorolac, etc. Like I said, they inhibit both COX-1 and COX-2. By inhibiting COX-1, it is actually causing an adverse effect. It is causing GI side effects. It's causing hypersensitivity reactions like urticaria, bronchospasm, angioedema, or even has renal effects, which are adverse. But by inhibiting the COX-2 and preventing the effect of the inflammatory mediators, it's exerting its anti-inflammatory, analgesic, and antipyretic effect. So non-selective NSAIDs is a double-edged sword with both adverse and beneficial. So the examples are ibuprofen. Now it's NNTs 2. That means it's a very good analgesic. For every 2 patients, 1, as compared to paracetamol, which is 5. And naproxen also has got a very good NNT. So these are the commonly used non-selective NSAIDs. Now, because of the COX-1 inhibition, it exerts its side effects. So it has got renal defects, gastrointestinal side effects, and it can cause a hypersensitivity reaction. That is because it is inhibiting the COX-1 enzyme. Now, the selective COX-2 inhibitors are inhibiting only the COX-2 enzyme, and it is preserving the COX-1 effect. So the examples are etoricoxib or Nucoxia. It's given as a single dose, 60, 90, or 120 mg a day, or celecoxib, which is given a dose of 100 or 200 mg twice daily, or diclofenac is also a COX-2 inhibitor. It can be given orally or IV. Its NNT is also very good. It's only 2, just like Brufen. NSAIDs can also be given topically, and they produce the analgesic effect with much less systemic absorption and toxicity. The examples are ibuprofen, diclofenac, piroxicam, ketoprofen. They are all available as gels and creams and sprays. Now, coming to the selective COX-2 inhibitors, are they really as safe as compared to the non-selective COX inhibitors? Now, where the GIT is concerned, it is definitely beneficial, but its renal effect can be comparable to the non-selective NSAIDs. On the other hand, it's got a disadvantages that it is prothrombotic, and there could be more incidence of myocardial infarction and stroke, especially in the susceptible people with atherosclerosis. So in fact, the rosicoxib, which was a COX-2 inhibitor, selective COX-2 inhibitor, was taken off the US market in 2004. And in such patients who are risk of getting stroke and MI, you can give ibuprofen and naproxen. They are safe in the high-risk cases. So if you look at the risk factors for NSAIDs toxicity, there are many. I will just highlight the ones in red. Like for GI toxicity, you can have GI bleeds. In renal toxicity, you should avoid dehydration. And particularly when there's a creatinine clearance of less than 30, you have to be very cautious and avoid NSAIDs. And if there are risk factors for stroke, like hyperlipidemia, smoking, history of TIA, diabetes, hypertension, then you should avoid using COX-2 drugs. Now coming to the step 2 drugs, okay, of the analgesic ladder, they are not controlled drugs, unlike the step 3 drugs, which is morphine. Okay, because they are weak opioids, so they are given for pain of moderate intensity, which is not controlled with step 1 drugs. There's no pharmacological need for step 2. It can be even skipped. And the commonly used step 2 drugs are tramadol and tapentadol. Now, coming to tramadol, it is a centrally acting synthetic weak opioid. It has a dual method of action. One is it is a opioid agonist. And because it is weak, it has less tendency for respiratory depression and addiction potential as compared to morphine. But it also acts on the descending inhibitory pathway of pain by blocking the presynaptic reuptake of serotonin and norepinephrine. So this is very important, particularly in the treatment of neuropathic pain. So these are the 2 methods by which this tramadol acts. It has a high oral bioavailability, very well absorbed orally. Plasma half-life is 6 hours. So you have to repeat it every 6 to 8 hours. The oral dose is very potent. It's 1/10 as potent as morphine. And like if you're giving 40 mg morphine, it works out to 400 mg tramadol. You divide the tramadol by 10 to get the equianalgesic dose of morphine. The dose is 50 to 100 mg every 4 to 6 hours. You can go up to 400 mg. Sustained release tablets are also available, which can be given twice daily. It has got some side effects like nausea, vomiting, dry mouth, constipation, dizziness, sedation. And there is a risk of seizures when the total dose is exceeding 400 mg. When you give it with drugs that lower the seizure threshold, like tricyclic antidepressants and SSRIs, or when you give it as a rapid IV injection. The other weak opioid of the step 2 is tapentadol. In fact, nowadays, they're even thinking of making it a step 3 drug because it is quite a strong drug as compared to tramadol. In fact, 50 mg of tapentadol per orally is equivalent to 15 mg of per oral morphine. This is also a weak opioid, structurally related to tramadol, and the method of action is also very similar. It is an opioid agonist. It's also acting on the descending inhibitory pain pathway, but the side effect profile may be better. The dose is also somewhat similar, and again, you have sustained release combinations. So if you look at the analgesic combinations, we should never use 2 drugs of the same category for treating pain. For example, you don't combine COX-1 and COX-2. Or you don't combine a weak opioid with a strong opioid. Okay, don't combine tramadol with morphine or tramadol with methadone or tramadol with fentanyl patch. And the combinations that are good are paracetamol NSAIDs with morphine, or paracetamol with NSAIDs, or paracetamol with tramadol. So these are the favorable combinations. Now let us move on to neuropathic pain. I've got, it's now 5:30, so I've got about 15 minutes left, Shri Priya?
Yes, ma'am. 10 to 15 minutes you can easily take, because this is an important topic. We don't want to miss out on anything.
Okay. So if you look at it, what is the, why is there need for adjuvant drugs? Okay. Now, cancer pain is not just nociceptive. It could be due to bowel obstruction, it could be due to bone pain, it could be neuropathic. In fact, 40% of cancer patients have neuropathic pain. Or there could be associated symptoms like depression, anxiety, insomnia, etc. So you need to treat all that as well, and that is why you have the adjuvant drugs. So adjuvant drugs have analgesic properties, but the primary indication is not for pain. And it is called co-analgesic because they are co-administered with other drugs of the WHO lab. If you want to classify the adjuvant drugs based on the clinical symptoms, you have multi-purpose and adjuvant drugs, and these include antidepressants, corticosteroids, and alpha-2 agonists. Or you have drugs for neuropathic pain. Okay, adjuvant drugs for neuropathic pain, which I will talk about more in detail as I go by. Then you have adjuvant drugs for bone pain, or for bowel obstruction, or for musculoskeletal pain. So there are, this is a broad classification of the adjuvant drugs. Now, if you look at this diagram, we can see that chronic pain can be nociceptive, where the tissue injury is causing pain at the periphery, at the tissue level, and that is why it's called nociceptive, because this is a peripheral nociceptor. But anything beyond this nociceptor up to the spinal cord and the brain, it comes under the peripheral and the central nervous system. And any pain beyond this is called neuropathic pain. So a neuropathic pain is caused by a disease or lesion in the peripheral or the central nervous system. This is the latest definition of neuropathic pain in 2018. Or it even can be a mixed kind of pain. It can be both nociceptive and neuropathic. Now, why does neuropathic pain occur in cancer? It's because of, first of all, it could be because of direct invasion or compression of the nerve. near the cancer, which could be a mononeuropathy or a plexopathy, because when it's a cancer is increasing in size, or when it is compressing the nerves, it can cause neuropathic pain. Or it could be because of the treatment of cancer. It could be the chemotherapy-induced peripheral neuropathy. It could be radiation-induced neuropathy. It could be after surgery, because surgery can injure a nerve, and that can cause neuropathic pain, like you can have post-mastectomy pain syndrome. And surprisingly, it even occurs in cancer survivors. The cancer has been healed, but the neuropathic pain can persist for months and even years. So let's talk about the treatment of neuropathic pain. The first important drug, I told you, this is a first-line treatment of neuropathic pain, is anticonvulsants. Now, why are anticonvulsants used for neuropathic pain? Because both convulsions and pain have a shared pathophysiology. In both, there is neuronal excitability, and these anticonvulsants are dampening the neuronal excitability. And the commonly used drugs are gabapentin, pregabalin, and sodium valproate. So if you look at the action of the gabapentinoids, which are pregabalin and gabapentin, it binds to the voltage-gated calcium channel of the alpha-2 delta subunit of the calcium channel of the presynaptic neuron, and it prevents the calcium influx into the neuron, and consequently the release of these excitatory neurotransmitters is decreased. And then there is, because of that decreased neurotransmitters, the excitatory transmitters like aspartate and glutamate in the synaptic cleft, there is less excitation of the postsynaptic neuron. But besides that, it can also act on the sodium channels by inactivating it, and it enhances the GABA-mediated synaptic inhibition. So that's the other two mechanisms also for how these gabapentinoids are exerting its analgesic properties in neuropathic pain. Now, if you look at gabapentin and pregabalin, the advantages are it is very well tolerated, and it less chances of drug-drug interaction, but it has got side effects like somnolence, dizziness, ataxia, fatigue, weight gain. So these have to be explained to the patient. And accordingly, you must give the drugs so that they do not fall or anything like that. You know, if a patient takes a drug very late at night, then next day they may be very drowsy. So you should tell them to take it early, you know, before 8 o'clock and things like that. So if you compare the two, gabapentin, the oral bioavailability is unpredictable, and it can, you need to slowly titrate the dose in multiple steps, but the advantage is it's less expensive as compared to pregabalin. Pregabalin, the titration is much easier, and it is supposed to be a very predictable oral bioavailability. Now, topical drugs are also now available for treating neuropathic pain. And now topical gabapentin is available. How effective it is yet to be said, but there is topical gabapentin now available. And another drug for neuropathic pain that can be applied topically is topical capsaicin in a pretty high concentration, which is 8%. Now, capsaicin is a pungent component of chili pepper. And it is, but this is not freely available in India. It's available in the Western countries. Now, coming to the antidepressants. This is also a first-line treatment for neuropathic pain, just like anticonvulsants. But the onset of analgesic action takes up to a week. And the analgesic effect is not dependent on the antidepressant effect. It occurs earlier and at lower doses as compared to the antidepressant effect. Now, when we give antidepressants for patients with pain, particularly cancer pain and chronic pain, it is very useful to treat the coexisting depression, anxiety, and insomnia that many of these patients suffer. How do they act? They again act by activating the descending inhibitory pathway of pain by preventing the reuptake of norepinephrine and serotonin. Now, 3 types of antidepressants are used in cancer pain. First is the tricyclic antidepressants, which is tertiary amines like amitriptyline or secondary amines like nortriptyline. Or we have the SNRI or the serotonin norepinephrine receptor inhibitor like duloxetine and venlafaxine. Or you even have another antidepressant, which is a selective serotonin receptor inhibitor, or the SSRI. The examples are escitalopram, citalopram, paroxetine. They are mainly used for anxiety and depression. It has got less analgesic effect as compared to the upper two drugs. So if you look at the analgesic effect, the TCA is more analgesic than SNRI, which is more than SSRI. But if you look at the side effect profile, again, the TCA has got more side effects as compared to SNRI and SSRI. Now, the side effects of TCA are the CNS side effects like somnolence, drowsiness, mental clouding, and even suicidal tendency. Anticholinergic effects of TCA causes the dry mouth, acute angle glaucoma, blurred vision, tachycardia, urinary retention, constipation, and orthostatic. These are because of its antimuscarinic. So, accordingly, the contraindications are you should avoid it in patients with severe cardiac conduction defects, those with prostatic hypertrophy, and those with glaucoma. You should avoid these drugs. If you look at the side effect and contraindications of SNRI, the side effects again, somnolence, dizziness, constipation, anorexia, sexual dysfunction. And the contraindications are venlafaxine should be avoided in patients with hepatic and renal dysfunction and those with high blood pressure. And duloxetine should be avoided in patients with hepatic insufficiency. The dose of duloxetine is 30 mg to start with, and you can go up to 60 mg OD. Venlafaxine is 37.5 to slowly increase to 70 mg, 75 mg. Now, if you look at the dose which are giving in neuropathic pain, antidepressants, you can start with amitriptyline 10 mg, and you can go up every 3 to 5 days, increase it to 25 mg, 50 mg, up to 100 mg. Similarly with nortriptyline. And duloxetine, I said 30 mg to 60 mg, and venlafaxine 37.5 to 75 mg. Anticonvulsants, again, gabapentin, you can start with 100 mg or 300 mg at night, and you can step it up to 1200 mg TDS, okay, 3 times a day. Pregabalin, again, start with 75 mg, you can go up to 450 mg. Remember, all the doses should be adjusted in medically ill and patients with renal dysfunction or hepatic. Now, what is the role of duloxetine in patients with neuropathic pain? That is chemotherapy-induced neuropathic pain, CIPN. So this was a study in 2013, and they found that those receiving duloxetine as initial treatment in weeks 1 to 5 had larger decrease of pain as compared to the placebo-treated patients. And so in the updated 2020 guidelines, they have suggested duloxetine for the initial treatment of painful chemotherapy-induced neuropathy for 5 weeks. The other drugs used in neuropathic pain are ketamine. Now, ketamine blocks the NMDA receptor, which is present in the dorsal horn of the spinal cord and also in the thalamus. NMDA receptors are present both here as well as in the thalamus, and it is used as a second-line treatment of patients with neuropathic pain. It has side effects like dysphoria, hallucinations, nausea, vomiting, dizziness. So you can prevent it by giving drugs like haloperidol or benzodiazepine. It can be given in a number of routes: IV, IM, subcutaneous, oral, sublingually, intranasally, rectally, topically, intraarticular, epidural, intrathecal. There are a whole lot of routes by which you can give ketamine. And it can also be given orally and IM, which is normally given. So ketamine is actually an anesthetic, but when you use it in sub-anesthetic doses, in doses of 10 to 25 mg TDS, it can be beneficial for neuropathic pain as a second-line treatment. You can also give it as a subcutaneous or an intravenous infusion in a dose of 50 to 100 mg per day, maximum 200 mg. Burst ketamine infusion can also be given for difficult pain, which I will cover in my next talk. The other drugs that can be given as a second-line treatment are the local anesthetics. They act on the sodium channels. They prevent the neuronal excitability by acting at the level of the sodium channel. And it is particularly useful for severe intractable crescendo kind of neuropathic pain. It can be given as an IV local anesthetic infusion in a dose of 5 mg per kg. You add it to 500 ml of normal saline and give it as a slow infusion over 1 hour with cardiac monitoring. So this has to be done in a hospital setting. The topical local anesthetics are also available as lidocaine patches. 5% patches are now available in India. You can apply up to 3 patches a day, but just remember, if you keep it for 12 hours, you should remove it for the next 12 hours. Otherwise, you may land up with local anesthetic toxicity. So if you look at the neuropathic pain ladder, the first line treatment is amitriptyline, pregabalin, and gabapentin, duloxetine, and lidocaine patch. The second line treatment is opioids and tramadol. And the third line is baclofen, mexiletine, capsaicin, ketamine, or local anesthetics. Now coming to corticosteroids. Corticosteroid, I said, is a multi-purpose drug. It can be useful in neuropathic pain, bone pain, headache because of intracranial metastasis, arthralgia, pain from obstruction of bowel obstruction, and also pain from spinal metastasis. And dexamethasone is the most common first-line corticosteroid that we are using. Its main advantage is a long half-life of 36 to 72 hours. So only once a day dosing is required. It's very potently anti-inflammatory as compared to the other steroids like hydrocortisone or prednisolone, etc. And it has got less mineralocorticoid effects, so less chances for sodium and water retention. But because steroids can cause insomnia, you give it in the morning and not the night dose. And it can provide short-term relief of pain, particularly since many of the cancer patients have less life expectancy. So in such patients, you can give steroid to decrease the pain. Then we come to the GABA receptor agonists. Now, GABA receptor agonists are actually potentiating the inhibitory effect of GABA. Now, GABA is it is a inhibition of the, it inhibits the neuronal activity. Okay, so this is actually it is potentiating the inhibitory effects of GABA. So there are two types of GABA agonists. One is a GABA A receptor agonist, which include the benzodiazepines. And the only benzodiazepine that's used for neuropathic pain is clonazepam. And the GABA B receptor agonist is baclofen, okay, which is used in treating pain with spasticity or muscle spasm. The dose of clonazepam, you can start with 0.5 mg per orally. You can go up to 8 mg. And for terminal sedation also, it can be used in a dose of 5 mg. We can go up to 2 to 8 mg 24 hours as a continuous subcutaneous infusion. Okay, so clonazepam has got usefulness in palliative care to treat neuropathic pain as well as for terminal sedation. Now, I mentioned about the GABA B receptor agonist, which is baclofen or lioresal. Okay, I've got a couple of minutes more, so I'll just tell that it is useful in treating spasticity, hiccups, musculoskeletal spasm. It can start at a low dose of 5 mg BD or TDs, and we can gradually increase. And it can be given orally or even as a pump, intrathecal pump, you can use baclofen. For bone pain, it's used to treat the skeletal related events. They can be very agonizing. And the drugs used in treating the bone pain are corticosteroids, NSAIDs. Calcitonin has not been found to be that effective, but bisphosphonates, denosumab, and palliative radiation is also very effective. So they act, bisphosphonates are acting by blocking the osteoclastic effect or the bone resorption. And the drug that is commonly used is zoledronic acid in a dose of 5 mg every 15 minutes, over 15 minutes every 4 weeks, up to 1 year. But it can cause, hello? I'll just take a couple of minutes more. So denosumab is another drug that can be given. It can be a little more beneficial than zoledronic acid, but it is more expensive. And then you have the palliative radiation, which can cause, decrease the pain, particularly when there are skeletal metastases. Pain due to bowel obstruction can be treated using steroids, octreotides, and anticholinergic drugs. And the other adjuvant drugs are the skeletal muscle relaxants, neurolepts like olanzapine, antibiotics, etc. So if you look at this pain pathway, you just see how the muscle relaxants are acting at the periphery, right, at the muscle level. Local anesthetic and NSAIDs are acting at the nociceptor level. Local anesthetics as such is acting on the peripheral nerve. The local anesthetic and alpha-2 agonists are acting at the dorsal root ganglion. Opioids, ketamine and gabapentin are acting at the dorsal horn. And drugs like opioids, alpha-2 agonists, and tricyclic antidepressant SNRI are acting on the descending inhibitory pathway. Okay. So this is how these various drugs are acting on different parts of the pain pathway. So when we come back to our case scenario, we know about this gentleman, which I told you, that he has got both a mild to moderate pain. His pain is both nociceptive, that is a gnawing pain, but because he has got burning pain in the arm, that is a neuropathic element also. It is worse at night, and he is also unable to sleep because there's a lot of emotional pain. So you can give him a combination of paracetamol with NSAIDs, but you may have to add an anticonvulsant and antidepressant for the neuropathic pain, and you may have to add an adjuvant drug like a sedative, along with psychosocial support for treating his other concerns. To summarize, like we know, I mentioned the WHO analgesic ladder is a sheet anchor for cancer pain management. It can also be used for non-cancer pain. And very important, it has legitimized the use of opioids in cancer and non-cancer. Thank you.
Thank you, ma'am, for the presentation. We already have a few questions in the chat.
Shall I stop the screen share?
Yes, ma'am. Yeah, I think it was about the tramadol that you said 110 potency of tramadol to morphine. Yes. So can you just tell that once more so that it is clear?
Okay. See, tramadol is a weak opioid, and also it is acting on the descending inhibitory pathway of pain. And because it's a weak opioid, it has got less tendency for respiratory depression and addiction potential. And if the equianalgesic doses, if you divide the dose of tramadol by 10, you will know the equianalgesic dose of morphine. So if you're giving 400 mg tramadol and you want to convert into morphine, then you have to divide it by 10. So it is equal to 40 mg of morphine. So that is why it is 10 times less potent than morphine. It's a weak opioid. So that so this is the reason.
Dr. Arnab, I hope that was clear. Dr. Sankhya has asked about the conversion, but I was telling if it is specific to morphine conversion, then we'll be dealing with the topic, the step 3 analgesics, where you will be learning from morphine to fentanyl and to tramadol and to methadone, all those conversions. But if it is from WHO, it means step 1 to morphine, then probably, yeah. Ma'am, there is a question on, is it advisable to give tramadol as a continuous infusion?
We don't give it as an infusion. If you want to give it IV, you can give it every 6 to 8 hours. You can give 50 to 100 mg tramadol, but it is never given as an infusion as far as I know. But when you give an IV, just make sure that you give it over 10 minutes or 15 minutes. Otherwise, you can land up with seizures and you can also have more vomiting. So give it as a slow infusion. I mean, I'm not saying an infusion, but only over 10 to 15 minutes to decrease the risk of seizures and to decrease the vomiting that can occur with them. But it is never given as an infusion as far as I know. I'm an anesthetist, so I've never given it as
Ma'am, is step 3 indicated in all steps or only after, the nerve blocks interventions indicated in all steps or only after step 3?
See, again, if you find that, see, normally mild to moderate pain, there is no need to give a nerve block, right? But if it is, say, moderate to severe, and if you feel there's a specific indication for a nerve block, then you can add it. It is not that you only give it when the step 3 fails that you give a nerve block. You can add it along with the step 3 drug, depending upon where it is. Supposing it is a tumor which is close to the sciatic nerve. Okay, and it's not getting controlled with morphine. You can give a sciatic nerve block or some steroid there or a continuous nerve block. So it doesn't necessarily mean that you can only add it as a 4th step. If you feel the pain is moderate and there is a specific indication, you can add it even at step 3 or maybe even step 2. But for step 1, it is invariably not required if the patient is controlled well with the step 1.
So is tramadol contraindicated in non-seizure disorder? That's the question, because it increases the risk of seizure episode. I think. Yeah.
This is the threshold for seizure. Okay. So that is why patients, and also the other drugs that decrease the threshold are TCA, and some SNRI. So we have to be very careful when we combine with that. But those with seizures, it can decrease the seizure threshold. So the chance of getting a seizure could be high. And also you should be very careful when you give it very, very slowly rather than pushing it. Then again, the risk of seizures is. But we are using tramadol so much, that I think even with patients, I'm a neuroanesthetist, so I've done so many patients who have seizures because of an intracranial tumor, but we are using tramadol. So it may not be that significant if you give it in a low dose. But definitely, if you give it more than the 400 mg, there could be a risk of seizures. But it is contraindicated in those with seizures.
Dr. Newster was mentioning, I don't realize there is a whole world of medications before the strong opioid.
Yeah.
So thank you for that comment. Yes, there are actually. And another question in palliative care, how often do we give intervention? Do we where do we place intervention? Is it rare, sometime, or most of the time?
It all depends upon the patient. You have to take it, but it all depends also on the centers in which there are some centers which are going in for interventions right in the beginning. So there are some, like for example, in Pallium, Shri Devi, you are treating so many patients using the WHO ladder. How often do you use interventions?
It's very rare, actually.
Very rare, na? But then it all depends upon the institution to institution.
Yes, it is all dependent on the institution, I say.
Exactly. You are treating so many patients. 75% of patients, you're getting good relief with the WHO ladder, right?
Yes.
And so rarely we have to go into, only intractable pain and all, we are going in for interventions. But there are certain institutions where if the patient has got a pancreatic cancer, they'll straight away go in for a neurolytic block. Okay, so it all depends institution to institution. It all depends on how conservative or how aggressive you are. So when you can produce the same thing with, after all, interventions have a risk of a adverse effect. Okay, it is not a totally risk-free thing. So if you can do the same thing with conservative management, then I would say that we should go in for conservative. Only when there is no relief with that, then we should go in for intervention. That is my thing. I am also very conservative fan.
Ma'am, there's a question on how long will the effect of nerve block stay, and do we need to repeat it?
Yes, that's a good question. So it depends upon for example, when you're giving a nerve block, like for example, you're giving a pancreatically, you're giving a celiac plexus block. So first you have to inject a steroid with a local anesthetic. It's like a diagnostic block. And if it's producing good effect, then you go in for a neurolytic block. Neurolytic block tends to be permanent, right? More, rather it is more longer lasting. But sometimes you can even treat it with just giving a local anesthetic with steroid. And if there's a good pain relief, it's good enough. But there are people who are even using a continuous infusions also, like a continuous brachial plexus block or a continuous sciatic nerve block. If the effect is temporary, then you can put in a catheter and give a continuous block. So it all depends upon how long lasting the effect is. But sometimes you can give a single shot and see whether, but anyway, even before giving a neuralytic block, you have to give a single shot block with a steroid and local anesthetic to see if it is working. Only then you go in for the neuralytic. Straight away, you don't go for a very aggressive treatment like neuralytic block without knowing whether it is going to be effective or not. But there are people are using continuous infusions, using the PCA pump and all, even for continuous brachial plexus block or continuous sciatic nerve block. People there are centers that are using that and sending the patients home with that. There is a risk of infection. We have to be a little careful about it.
Dr. Aisha is asking about transdermal patches. Dr. Aisha, you mean the lignocaine patches or fentanyl? If it is fentanyl, then that is covered in step 3.
But there is transdermal, even diclofenac patches are available.
Okay. I think she's asking about that.
New patch. It's called new patch. The trade name is new patch. But I've never used it much. I find that oral NSAIDs is quite good. And I don't know how you, I mean, I've not much experience with the diclofenac patch. I think oral is quite good. The bioavailability, oral bioavailability is quite good.
Maybe one last question. In patients with renal failure or renal injury in palliative intent care, do we still need to worry about giving NSAIDs and TCAs in cardiac problems?
See, definitely when there's a renal dysfunction, we will try to avoid NSAIDs. Okay, there are other options available like paracetamol, tramadol, tapentadol, or you can even move on to the step 3 drugs. I would avoid all NSAIDs in patients with renal dysfunction, particularly if you're monitoring the creatinine clearance and that is less than 50 ml, then we should avoid it because we have got other options available. We don't have to give an NSAIDs. You can move on to step 2 drug like tramadol, or even paracetamol is quite good enough to treat. That is about NSAIDs. No, I will avoid it in patients with renal dysfunction. And the other question is, what did you say?
TCAs in cardiac problems.
So because TCA can cause tachycardia, we should avoid it in patients with heart failure and those with cardiac problems like conduction defects and all those things, palpitations and all, you must avoid these. So when you give a TCA, we have to screen the patient. Do they have glaucoma? Do they have a prostatic hypertrophy? Do they have cardiac conduction defects? Or for them, even if they are very severely constipated, this can cause constipation, but that's not so important. You can treat it. But in other 3 conditions, we would avoid TCA. Instead, you can give an SNRI, which may be more beneficial.
I think, one last question. Tapentadol in renal failure, liver failure. Should we avoid tapentadol in liver failure?
It all depends upon the extent of liver failure, right? So if it is definitely you have to reduce a dose of tapentadol, but I don't think it is contraindicated in liver failure, but dose adjustment definitely has to be done. And it all depends upon the extent of liver failure, how much are the SGOT, PT and all are elevated, So if it is a moderate liver failure, I think by dose adjusting, it should be good enough. And I'm sure a dose of 50 mg twice a day will not produce that much effect. Liver dysfunction. Liver failure is a totally different thing. In liver dysfunction, I presume that you can give it after appropriately addressing the dose.
just remembering the NSAIDs and renal failure, I think many places these days nephrologists recommend NSAIDs for, I mean, they're okay in giving NSAIDs for renal failure. Last few discussions with some batches, we've come across cases where they have told it is okay to give NSAIDs when they are on dialysis specifically. So I just wanted to share that. Thank you so much. I think we'll just take the case presentation and then come back to the discussion. Okay.
Hello.
Yes, ma'am.
Shall I start?
Yes, please.
Yes.
Hello, myself Dr. Priyanka, and I'm working in GMC Haldwani. I'm presenting a case of a 48-year male patient who got admitted in our hospital, and he was diagnosed with carcinoma tongue with nodal metastasis with bony mets, and he was stage 4, and he was a case of diabetes. When he presented to us, he had pain in lower abdomen and chest since 12 days. And he was apparently asymptomatic 1.5 years back when he developed difficulty in swallowing, and he had oral and tongue ulcers and a gradually increasing neck swelling. So he visited his nearby doctor, and tongue biopsy was performed. And the report read as a squamous cell carcinoma, moderately differentiated carcinoma tongue, and he was operated for carcinoma tongue. In the post-op, he received 35 fractions of radiotherapy and 7 fractions of chemotherapy, and for 10 months. And PET scan was also done, but he did not brought the report to us. After 5 months of this chemo and radiotherapy, he developed pain in lower abdomen, including pain in chest from 1 month. And when the intensity of pain increased, he visited our radiotherapy department. Pain was aching and stabbing in nature and lasted whole day. And the pain was relieved in lying down position. Some days later, when he was admitted in our side in palliative ward, he developed breathlessness also, and he had to be put on Hudson oxygen mask, and on mask his SpO2 was 92% on 6 liters of oxygen. On examination, his CNS was within normal limits, and he was afebrile. Respiratory rate was 21 breaths per minute, and BP was normal, and an RT was needed to be put. His investigations were done. Hemoglobin was on the lower side, and TLC count was 7,500, 3.5 lakhs platelet count. Serum sodium was little less, 130 milligram per DL. Since he was diabetic, his HbA1c was 6.8, and he was on tablet metformin 500 mg BD and tablet vildagliptin 50 mg OD. So the psychosocial aspects of this case deals with the life of this 48-year male patient, and he is the breadwinner of the family. He belongs to a low socioeconomic status, and he had to spend his
Dr. Priyanka,
years back. Now he had total 3 daughters, and now 2 of them are waiting to get married, and he has no source of income while he was ill in these months, and now he feels himself physically weak to continue his work as carpenter, and their finances are required for treatment and marriage of daughters. His daughters now refuses to get married to look after him, and he is concerned about them after if he dies. So patient VAS score when he came to us in our ward was 6/10, and he was advised tablet paracetamol 500 mg TDS, tablet tapentadol 100 mg BD, and tablet gabapentin 100 mg HS for 2 days, and then later 100 mg BD. And since he was complaining of loss of appetite, one syrup was added. And now patient was relieved of this pain, and his VAS score got reduced to 2/10. Now main concerns is after admission to in our ward, after 2 days, the patient had complaint of breathlessness and needed oxygen support and feeling of generalized weakness, and since RT was put, he felt irritable during feeds and feeling of hopelessness. So this is the case of a 48-year male patient, carcinoma tongue with nodal mets and bony mets, with known case of diabetes, now with complaint of breathlessness with RT in situ. Discussion points. That there is deterioration of health, breathlessness, and progressive tachypnea. Need to provide palliative care to the patient, management of issues of generalized weakness, loss of appetite, loss of sleep, and anxiety, and the problem faced by the patient and his family, and what can be done for them.
Thank you, Dr.
Thank you.
Much for the other participants, how to go ahead with this. We are dealing with breathlessness later. Maybe we can focus on the other issues and maybe specifically for pain. Dr. Priyanka, there is a question in the chat. Do you have anything to say about the reasons for breathlessness in this patient? Dr. Priyanka, are you there?
Hello. Yes, ma'am. That could be due to his metastasis, but bone scan report, PET scan was not available to us. So probably due to metastasis. Bony mets were already there, so might be in lung also.
Whether you have done a chest X-ray for this thing.
Yes, ma'am.
Hello.
So I would like to ask Dr. Priyanka, what was the status of the pain? You mentioned pain in the beginning. Sorry if I missed, maybe I didn't understand it.
It was on the VAS scale, it was 6.
Okay, and he was okay with tramadol?
Yes, tramadol and tapentadol and gabapentin. He was relieved of pain.
Okay. So what is like tramadol and tapentadol or?
Sorry, tapentadol and PCM and gabapentin.
Okay, okay. And it is well controlled with all 3 medications?
Yes, yes.
Okay, okay.
Any idea what the X-ray chest has been done, Priyanka?
Ma'am, X-ray chest was not done. Yeah, it could have been done. And later, ma'am, a patient deteriorated fastly. So we couldn't take him to another, in that department of radiotherapy, chest X-ray facility is not available. We have to shift to him to our other hospital, our general hospital.
Yeah, I think others have also asked about the examination finding. Ma'am, what do you think about this particular patient? Like, how can we help him to relieve the symptoms? Mm, I don't know, the loss of appetite, loss of sleep, and anxiety. Um, yeah, a lot of problems to solve here. And what all can be done for the patient? I know this is not specifically for pain, but it will be good to hear from you how to go about. Ma'am, would you like to comment on the general management? What all things could have been done?
I don't think pain is a big concern. I think the pain has been controlled, right? I don't
Yes.
think. So I think that in the absence of a chest X-ray, but the saturation is 92%, has oxygen therapy been given to this patient? Is he getting oxygen?
Yes, ma'am. He was on oxygen, 92% on simple oxygen mask, and tachypnea was increasing. Ma'am, later patient progressively had breathlessness, and he died within 1.5 days.
Died. The same patient?
Yes, ma'am. So basically, patient didn't pain was controlled, but patient died of this respiratory component. Breathlessness was aggravated.
Yes, so there is a comment from Dr. Aisha. Pain is controlled with medication. Maybe chest X-ray to rule out the metastasis or aspiration. Psychological aspects needs more care. Support to family. Thank you, Dr. Aisha. I think yeah. Is there any role for steroids here? What do others think about it? Do you think steroids would have helped? Dr. Jason, would you like to comment on what exactly you expect out of steroids here? Like there are many roles for steroids. Like what exactly you are indicating here about steroids?
I think the multi-purpose effect of steroids, having the compression thing and the pain thing also. And I think sometimes like in if there's a met and there's an edema and something like that, it can help. It's just a trial. Because we had one patient whom I want to present. He had the same thing. He gave some steroids was helpful. Though it was quite helpful in brain meds, I feel that maybe some effect of the strong of the dexamethasone. I thought because it's got a respiratory component that will also help if there is some other associated, he's a diabetic, he had associated any reactive disease. These all can help him in the inflammatory aspect of the. That's what I thought. I thought that would have.
I think there is no harm in giving him some steroid like dexamethasone, like because see, there could be even in respiratory failure. Sometimes there could be steroids can be beneficial, and also if there is other, because we have not much investigation, we don't know whether there are intracranial metastasis and is there a spinal cord compression. So in all this, steroid can be beneficial, and steroid can definitely provide short-term benefits, particularly in the terminally ill patient.
Thank you, Dr. Jason. I think there are questions related to morphine and dyspnea. We have a very one whole session on respiratory illness or respiratory symptoms, where good debate on the morphine and or the breathing, thinking, anxiety cycle of breathlessness. So we'll come to that. But yes, morphine has a definite role in management of breathlessness, a big time role actually in a palliative care setting. So what about asking, sitting down and asking the patient about the loss of sleep and anxiety and the weakness part? I think that is where we can start with. Ma'am, what do you think about it?
I think that we should, all these issues are causing him a lot of anxiety about his future, of his daughters, etc. So I think there could be a anxiety element could also be contributing to his restlessness and things like that. So maybe we can give him some, anti-anxiety medicines like clonazepam or olanzapine or something like that, along with psychosocial counseling. I mean, trying to just sit with him and try to figure out what we can do for the future of his daughter. But I think a medication to reduce his anxiety and depression may also help. Something like a terminal sedation, like you can give, along with morphine, you can add an anti-anxiety drug also, I believe. Allay his anxiety to a certain extent, along with, of course, counseling. And loss of sleep, all these things are there. So maybe, although we'll be a little hesitant to give it, in particularly when there's a respiratory failure, giving it, but then you have to, weigh the pros and cons and then give it, I suppose.
Dr. Priyanka, there is another question to you. So in terms of managing this patient, was managing the patient, was the patient deterioration was more concerning, or the family who were unable to handle the rapid progression, which was more concerning when you dealt with this patient? I hope you understood the there are two aspects for it: managing the symptoms and making the patient comfortable, and handling the family who has to go through a rapid progression and maybe kind of uncertainty in things happened in between. Yeah, so there is a response, and the patient's condition was more challenging. So for isolated bony mets for pain relief, we can give palliative RT at the most tender point. Rightly said, Dr. Jyoti. Yes, that's very important. So that should send a proper referral at the right time to the radiation oncologist back, so that he can get a palliative RT for bone mets. There is question on steroid, ma'am. How about the dose and admission of steroid administration? I think start in PET tube or intravenous.
We can give it through if the Rice tube is there, we can give it through the Rice tube only.
Yeah.
We can give a dose of 8 mg daily for 5 days. Dexamethasone. It can be given through the Rice tube.
Yeah, got it. Is there any other questions that I did not see or I did not attend from the beginning? If the pain is not relieved and being dyspneic, can morphine be given? For Dr. Jason, you mean to ask if the patient is not having any pain, just breathlessness, can we give morphine, right? Just for breath.
No, I was just telling because this patient was on circulated oxygen.
Yes.
Still the pain is not relieved. They said pain is relieved by tapentadol. But
Yeah.
if the pain is not relieved, can morphine be given? That's my question. Because it can cause respiration in high dose, but can it be given? And if something happens, the patient should not say that just because of morphine. That's my only question.
Yes.
Yeah,
I understand. Yeah. So again, my quick answer would be yes. I think morphine will be the ideal drug for this patient because he had pain as well as breathlessness. So one medicine for both. But we'll come to that in detail. Like you said, will they blame or will be will that be an issue if something happens? So how we can avoid that something happens will be dealt in detail for sure. We have a session on that. Ma'am, slightly out of the context for today, but discussion on avoiding aspiration when using Rice tube feeding at appropriate. Is that something that you would like to take it up, or?
Yeah, the thing is, whenever this Rice tube is there, and again, the patient should be propped up at the time of the feed. And because the Rice tube can actually can tend to cause aspiration also. So we should give small feeds and keep the patient propped up for some time, and then only the patient should be lying down. So during feeds, they should be propped up. That is a basic thing about Rice tube feeds. And because otherwise, and if the patient is getting more and more sort of obtunded, then maybe at some point of time you may have to even stop the feeds, and the very terminal stages, I don't think there is any point in feeding much also. Even if the feed is being given, it should be given very small feeds. But when the patient is really terminal, no, Sridevi, I don't know what's the role of rice tube feeding in terminal stages of cancer. And I think they have to just switch over to IV fluids or something.
We still see aspirations with rice tube. How we should do the head of 30 and patients still aspirate because of mainly the micro aspirations.
Yeah, micro aspiration cannot.
So again, steroids and diabetes. Can we use steroids when the patient is diabetic?
See, when we have to control the diabetes, but that itself is not a contraindication for using steroids. If it has to be used, it has to be used. But control the diabetes by giving appropriate drugs. That's it.
So what we do in our setting, if whenever we start patients on steroid, if they are not diabetic, we check the status like once a week at once in 5 days. If they are diabetic, we check that on every 3rd day, and we just increase the dose of insulin if they are on insulin. So good diabetic control, but we don't avoid steroids, because many a times in palliative care we do use a lot of steroids for many symptoms like pain, breathlessness, obstruction, many uses. So but we'll keep an eye on diabetic, good diabetic control, as madam said. Are there any other questions? And I think, Dr. Shalin, I think it all depends upon the risk versus benefit.
Exactly.
And where exactly in the illness trajectory the patient is on, which is more important at that stage of illness, whether it is the good diabetic control or a good symptom control. So that's, I think that's where the balance, there is no clear-cut answer. No, you can give steroids and diabetes. So it's all depends on the illness trajectory and where exactly the patient is in that trajectory. Yes, Dr. Rajni, once the pain was controlled, maybe we should. So Dr. Rajni is telling we should have been more aggressive in investigating the cause of breathlessness. I think we all face the problem with lack of getting documents from one place, especially when you in palliative care setting, they come up with no documents at all. Many times the cancer center, they keep all the documents and they don't know how to take a copy of it. And we end up in having nothing in our hand other than patient and some symptoms. So that's a very common thing, I think, in our country. But yes, maybe if we had more information, we would have like palliative RT or something we could have explored. But I think pain was controlled. Yeah.
Because a sudden onset of breathlessness could either mean that he is aspirated or is there a metastasis.
Yes, yes, very true.
He be determined by at least getting a basic X-ray test done.
Anytime we don't get to diagnose to that part. Dr. Arnab is asking, I think I'll take up that question. Is there any mechanism to support the relatives of cancer patients when the breadwinner dies or is unable to earn anymore? I think in Kerala, we have this cancer patient pension where the cancer patient as well as the caregiver will get a caregiver pension. It is a very low amount. I think it's 1,000 rupees or something per month, but that makes a lot of difference for them. And there are certain schemes, government schemes, which are available. I think it's important when you start working in palliative care to get an idea, just collect all those information. I can share whatever we have in pallium to understand. Like, there are so many schemes which patients don't explore, and it is not about giving them that there is a scheme. One of our social worker makes sure that they get to fill the forms. Many times they don't know how to fill the form, where to give it, and they just stand in the queue. No one takes care of them. So they take an extra step, filling the form and then making a few calls. We ask the volunteers, can you just call the village officer and tell this is our patient? We send a separate letter. So one extra step will make that journey much more easier. So understanding the schemes, if you're working in an institute where you have a social worker or any service, just ask them to give you a list of schemes which are available in the government. Or if you just make a call in your, like, we have a social justice department, so we just call them and tell them to send a document which all schemes are already available. So that list is very important, and then just taking that extra step to help them to reach there than just telling there are schemes.
But Sridevi,
Yes,
Kerala is very, very advanced with the systems.
yes.
I'm sorry to say that in other parts of India, it is not like that. In Kerala, they really take care of it at the grassroots level, which is not, it's non-existent in many places. So what is there in Kerala does not apply everywhere. You know? And I wish it was, I wish Kerala has shown the way, but we have to, because this kind of thing is not available in other places. Kerala is way ahead by palliative care.
Dr. Shabnam is telling in Himachal also there are a lot of schemes. I think, ma'am, I think central government also have many schemes which we don't even know. Once you start exploring, there are so many schemes for children's education, for disabled people. So it's important to understand, have an idea about what is already available. Dr. Shalin, I just wanted to clarify that investigations and palliation, are you thinking, when do we stop the discussion or when do we stop the investigations in palliative care? Just wanted to clarify.
You know, the traditional mindset is that if a patient has gone into palliation, then you sort of climb down, you scale down. But what we are talking is what we actually practice. But sometimes people ask me, why are you investigating even these basic investigations? The person is almost certainly going downhill. I would say that probably we investigate to ease suffering by pinpointing causes and being precise in interventions, again to relieve. But this debate nevertheless comes up, and particularly in hospice care, they have no investigations. It's a one-way ticket in hospice. In hospitals, you can still investigate, and there are clinicians working there. So I just brought this up both as a curiosity as well as a thinking point, a philosophical point, and I hope that our experts will be able to give us, be able to articulate this with clarity, maybe some strong take-home message or a single, phrase or something. How do we do it? I don't know, really.
Thank you, Dr. Shalin, for that question. I think whenever I talk to people, I tell them that when you refer patient to palliative care, it doesn't mean that we are just giving up everything. If there is something correctable, it's not, palliative care is not equivalent to giving up everything. We focus on correcting the correctable if that is going to be beneficial for the patient. Right. So for correcting the correctable, whatever minimum investigations, if you want to know the renal status, I won't tell them to do the renal function test. I'll tell them to check the serum creatinine. I'll just get a rough idea. And that makes a lot of difference in terms of cost. So it's very different when it comes to the cost factor. So if I want something, I won't do the whole set. I just want to get a rough idea about the renal function, and just creatinine would do. But yes, the another point is when to stop. We need to learn when to stop. Otherwise, even when the patient is dying, we think that okay, there is a sepsis. Of course, your immune system is shutting down. You are prone to any kind of infection that comes near you. I still remember Dr. Rajgopal telling you can't die with 100% saturation and all the electrolytes absolutely normal, and then you die. Other than that, you are hit by a bus or something. You have to have these parameters going down when you're taking the natural path. So that is something that we need to recognize and understand. Okay, this is the time that we should stop looking at the papers and look at the patient. So we had a wonderful discussion by Dr. Frank Ferris from US. He was telling, shift the focus and tell the relatives to sit near the foot end, not near the monitors. Just tell them to stop looking at the monitors and sit at the foot end. So that and especially for feeding also, because when you are near the patient, you keep feeding. So shift gently to the foot end of the bed, so that they stop giving a lot of feeds and looking at lot other more and more of investigation. So yeah, very, very valid point. I think that's very important to know when to stop. And when you know that it is time to stop, you have to have the discussion with the family. Like, what is the primary focus? Setting the goals, like what they want, whether they want the sodium to be okay or whether they want the patient to be comfortable. I think that's something that we need to talk to the relatives when we know that. And I think on the other side, doctors need to know when to stop.
And another thing, even the patient sometimes says, stop everything. Okay, they articulate. So patient autonomy is also very important. When they say, I don't want anything more, I think we should respect that patient. I had a patient who was on a home ventilator, elderly 94-year-old lady. And we brought her successively from the hospital home, and home ventilation and mini ICU had been created. But at one time, even that old lady at 94, wrote on a paper, stop everything while on a ventilator. Can you imagine? So when they say that, we have to respect it. So stop everything. So what we did was we extubated her and put her on a non-invasive ventilator. She was at least more comfortable that way. So the patient can also decide sometimes, and we have to respect. Just because they are weak and not able to, articulate very well, but if they express a wish, we should honor their wish. I think.
Thank you so much, ma'am, and thank you so much for many of you have brought out wonderful points for discussion. Not just we didn't stick on to the pain part today, but it went really well. We touched upon many aspects, and I assure you that we'll cover most of these aspects in the coming sessions, especially communication, respiration, end of life care, and the ethics of giving or not giving a treatment at some points. Thank you so much, ma'am, for getting involved in these discussions. And thank you so much, one and every participant to make it very, very interactive and asking those questions so that we can all think about it and learn a lot from that. Thank you so much, Sripriya.